Well, we should first ask ourselves, what do space travel and assist devices have in common? And one commonality is that people were thinking not only of biological heart replacement, where the Leota Cooley artificial heart was implanted in April of 1969, but that very same year in July, we went to the moon. And so the search for our universe and the search for the seat of our soul was quite common all the way back decades ago. But we have seen a shift into invasive Laplace therapeutics in advanced heart failure. And what I mean by this is that the direction of treatment in terms of neurohormones, cytokines, and growth factor manipulation with guideline-directed medical therapy in advanced heart failure shifts towards the paradigm of mechanical stretch and strain addressal. In this case, various stress and strain-related surgical options have been tried. For example, people have tried remodeling surgery, and then that has not worked very well. People have tried passive restraint. That has not worked very well. People have tried cardiac resynchronization therapy, which is a form of decreasing cardiac stress and strain, and certainly that has improved survival. Cell therapy with
I'm immensely pleased to be with you
stem
today
cells
to present
and
an
other
update
techniques
on
has not
LVADs
really
in
been
advanced heart
very
failure.
useful. The only therapy
Well, we should
that
first
to
ask
this day
ourselves,
has consistently
what do
shown an
space travel
increase
and
in
assist
survival
devices have
over
in
the
common?
long term
And one commonality
is
is that
ventricular
people were
assistance
thinking
in
not
advanced
only
heart failure,
of biological
followed
heart
by
replacement,
biological
where the
replacement
Leota
of the
Cooley
heart.
artificial heart was implanted in
Now,
April
the
of
road to
1969.
creating an
But that very same year in July, we went to the moon. And so the search for our universe and the search for the seat of our soul was quite common all the way back decades ago. But we have seen a shift into invasive Laplace therapeutics in advanced heart failure. And what I mean by this is that the direction of treatment in terms of neurohormones, cytokines, and growth factor manipulation with guideline-directed medical therapy in advanced heart failure shifts towards the paradigm of mechanical stretch and strain addressal. In this case, various stress and strain-related surgical options have been tried. For example, people have tried remodeling surgery, and then that has not worked very well. People have tried passive restraint. That has not worked very well. People have tried cardiac resynchronization therapy, which is a form of decreasing cardiac stress and strain, and certainly that has improved survival. Cell therapy with mesenchymal stem cells and other techniques has not really been very useful. The only therapy that to this day has consistently shown an increase in survival over the long term is ventricular assistance in advanced heart failure, followed by biological replacement of the heart. Now, the road to creating an LVAD has been long and winding, and this is a big challenge because we went from these large, bulky pulsatile flow pumps to continuous flow pumps, which now have transitioned to the most commonly available pump called the HeartMate 3 pump, which is a very unique pump, as we will discuss momentarily. Well, many devices have been tried, but the two commonalities are, one, that these devices have gone from very large, bulky devices with multiple moving parts to very few moving parts and very small devices. And the second is that many of these devices have been tested and have faltered in either preclinical scenarios or in early clinical scenarios, with only 3 devices making it to global use: the HeartMate 2 pump, the HVAD pump, and the HeartMate 3 centrifugal flow pumps, which have now been replaced largely by just the HeartMate 3 pump, whereas the HVAD has been removed from distribution and the HeartMate 2 is used very sparingly. To understand continuous flow LVADs, one needs to understand its pathophysiology, and indeed, continuous flow VADs show a reduced pulsatile flow. They increase resident shear stress as blood cells transition through them, and of course, the metal interface with the blood creates contact pathway activation, as a result of which a conglomeration of hemocompatibility-related adverse events are noticed, which have the basis of an acquired von Willebrand disease, hemolysis and inflammation, and thrombin generation.
Due to this, we have commonly, for decades and decades, used either a vitamin K antagonist targeting an INR of 2 to 3 for all patients, as well as aspirin, which only recently for the HeartMate 3 has been shown to not be necessary. And I'll go over that result of the trial called ARIES with you in a moment. Now, hemocompatibility-related adverse events are unique in the form of either ischemic strokes, largely, very few hemorrhagic strokes, de novo pump thrombosis, and non-surgical AV malformation-related bleeding episodes. The HeartMate 2 pump was unique in that it resulted in the highest risk of pump thrombosis. The HVAD pump was unique in that it resulted in the most strokes, whereas the HeartMate 3 has been one of the most well-engineered pumps and is widely used worldwide today, mainly because it has nearly eliminated pump thrombosis. It does not cause many strokes other than during the perioperative period, and these are mainly surgical strokes. And the reduction in non-surgical bleeding has been modest but incomplete. As a result of this, this pump has shown an improved survival with a median survival that now exceeds 5 years, mainly due to a reduction in hemocompatibility-related adverse events. Now, the type of patient population in whom we implant these LVADs, where these are now implanted even for destination therapy in patients who have been deemed ineligible for heart transplantation, is such that we choose patients who either have a median survival of less than 1 year. These are typically advanced heart failure patients who are bound to inotropic support, or to those ambulatory advanced heart failure patients not yet on inotropes who have a median survival that is somewhere in the realm of around 18 months, even with best current medical therapy. And we can very convincingly improve survival almost 5-fold by increasing their median survival to greater than 5 years, while these patients maintain a functional capacity of almost 70% in NYHA class 1 or 2 symptoms of heart failure, with a 2.5-fold improvement in 6-minute walk distance and a 75% increase in the KCCQ scores, depicting a nearly doubling in the quality of life for these patients. Now, these gains have all come on hemocompatibility-related adverse events, and we still have some work to do even with bleeding, as a result of which the concentration on residual risk reduction has become quite an important focus. But even as we move to try and reduce the residual risk with infection rates, with bleeding risk reduction, decrease in heart failure-related hospitalization, and improvement in pump optimization, we must realize that timely referral for LVAD implantation remains the Achilles heel. We still often see patients far too late in the course of their disease, and there's a need for consistent communication, action, and the use of clinical aids, which we have actually advocated for. In many countries around the world, there are challenges of cost effectiveness because these devices can be quite expensive. And there are situations where in some countries, it is much, much cheaper to receive a heart transplant than it is to place left ventricular assist devices. In other countries, like in the US, we are challenged with the implications of organ policy changes, where the organ policy changes sometimes dictate whether or not we move patients towards an LVAD or not. Now, I'd like to go over the most recent international pivotal trial called the ARIES study, which I was privileged to chair. And this particular trial tested a very simple concept of elimination of aspirin as part of the antithrombotic regimen with the HeartMate 3 pump. And we were able to show a 35% reduction in the risk of non-surgical bleeding episodes just by a simple maneuver of removing aspirin from the antithrombotic regimen and only using a vitamin K antagonist alone in these patients. This mere action resulted in a 47% decrease in hospitalization days due to bleeding events and a 41% reduction in the cost of care. So we have moved the technology even closer and closer and closer to cost effectiveness for almost all regions around the world. But we still have some challenges, and one of the challenges is the treatment of the right ventricle or the unsupported ventricle. It turns out that because of the abnormal characteristics of blood flow, where we take blood transapically and then move it into the ascending aorta, one actually creates mechanical dyssynchrony of the septum. It causes dilation of the right ventricle, poor coaptation of the tricuspid valve leaflets, and it results in the uncovering of right heart failure, also because the preload to the RV increases the stress on that already diseased particular chamber. Now, the unsupported ventricle and right heart failure is difficult, if not impossible, to predict. And so it is a bit of a challenge to us still as to which patients will actually get through with just an LVAD alone and who won't. But I'm pleased to tell you that most patients will. And even those who require temporary right ventricular assist device support are typically able to be weaned off those pumps without much trouble. We now have seen a changing epidemiology of deaths at 5 years with the HeartMate 3 pump, where in fact most of the deaths tend to be conglomerated into cardiovascular deaths, with heart failure, ventricular arrhythmias, and other cardiovascular deaths leading the edge, as opposed to the older generation devices where it was mostly stroke, pump thrombosis, and bleeding-related deaths. Another big challenge that we still have is to free the patient from an external driveline. We still require an external driveline that is required to power these pumps, as a result of which we will often see infection in these patients. Very often, about a third of patients will develop some form of an infection at the driveline exit site, as a result of which a lot of engineering has focused on trying to create fully internable devices that can be powered with systems such as a transcutaneous electrical transfer mechanism, which is very similar to the iPhone charging mechanism, or perhaps to coplanar energy transfer systems. Now, these have not been able to see the light of day because there are significant battery capacity and engineering challenges, as a result of which some of us, until we get to a fully internalized device, have developed skin-like substances in partnership with our engineering colleagues at MIT. This is a substance called bioadicil, which we actually can, in fact, insert and occlude the driveline exit site in such a way as to not require repetitive dressing changes or decrease the risk of biofilm deposition and infection at the driveline exit site. This particular technology will be entering into a clinical evaluation phase very soon, and we hope that this will be a reasonable interim solution until we can find a fully internalized device. Now, we are working on physiologic flow smart pumps, and this is one such device that seems to actually be one with promise. This is a device where the pump is intraventricular and flows from the ventricle directly across the aortic valve and in a direct, more physiologic manner. It has an internal TET coil which fully internalizes this pump. This is a synchronized device that in fact can provide 5 liters plus of cardiac output. It is wireless power, which requires very little battery power of about 1 watt, and provides physiologic function. I always look at this device or the currently available devices as the difference between Taekwondo and Aikido. For instance, in Taekwondo, it's a contact sport. Our current devices change the pathophysiology of the blood flow, whereas these devices, the newer devices that we are testing now, are like Judo or Aikido, where they use contractile reserve and try to improve the patient's outcome in that manner and give more physiologic flow. We believe that this may also help the right heart function more normally. Now, the future of bioengineered LVADs is depicted here in this schematic, which includes the creation of more biocompatible surfaces so that we can avoid the need for anticoagulation, fully internalized devices that can be powered, fully pulsatile and physiologically responsive flow devices, as well as those that can provide transaortic flow and protect the right ventricle, as well as preserve von Willebrand factor and not cause bleeding. But there are some patients in whom biventricular support is required, and we're working on devices with that. Xenotransplantation is very, very early in its scientific discovery at this time point, but this may act as a bridge mechanism in the future and would most likely be prepared to be evaluated against biventricular devices. And then there is also the possibility of myocardial remission and recovery. And I want to give you a few words about this. The normal heart that we encounter is one that has elasticity. And in this situation, it's like a rubber band where if you stretch the rubber band and release it, it returns back to its normal shape. On the other hand, in heart failure, we typically see a plastic heart, which has actually advanced to its limits of almost a fracture limit. In such a case, it's like a paper clip, where if you open the paper clip and then try to close it back, it might still work as a paper clip, but it will remain significantly deformed. There has been a trial called the RESAGE trial that has shown that up to 40% of patients could achieve remission, but these are a very, very select group of young patients, less than 60 years of age, mostly less than 50 years of age, with less than 5 years of onset of heart failure, mostly 2 years of onset of heart failure, and almost all are non-ischemic patients. In such patients, one can in fact prolong their net life by using LVADs first as a bridge to remission, and if that doesn't work, then consider transplantation so that the longest lifespan can be accorded to these individuals. We have even tried to investigate bolstered facilitation of healing of the LV using mesenchymal stem cells during LVAD implantation. And unfortunately, I regret to tell you that this technology has really not moved the field forward at all. And the only trial in this field that was prospectively done showed no signal of remission or recovery. So I want to tell you that we have a number of global challenges and collaborative opportunities that are device-related, and we've talked about those. But there are also management-related issues where we need to actually look at the background medical therapy. There are market dynamics. We need more devices to enter the field to decrease the overall cost and availability of these devices. And we have an implementation-related challenge of ensuring equitable access, and we need to move forward in this regard. But the future is very bright. We are working with our colleagues at MIT who are now on the verge of creating a biorobotic heart using the tissue that has been created to be skin-like or now cardiomyocyte-like with thermistors implanted in it that can be actuators that can in fact provide contractile reserve in areas of scar, for instance. And maybe this is a future, because imagine where we've come from the treatment of anasarca with the use of tubes that would basically drain edema fluid into milk jar-like bottles, and patients would go home with infection and no antibiotics to treat them.
Consider yourself less enthused with devices and are only using ECMO. I can tell you that I have the greatest regard for the quality of care that each one of you provide your patients, and thank you for the service that you provide to the medical community. Now, these devices, at least where we are, have now reached a point where they are mostly being implanted for patients who have been deemed not to be transplant candidates. And I offer you 2 points of discussion with that. First, I think that the first point is that 80% of these devices are placed in patients who no longer are candidates for transplantation. In these patients, the devices improve their survivability by more than 5 to 7 years at this stage. And so while we don't have the experience in the long term, and we have some patients who have actually gone out to 10 years now, we're just seeing it because the device has only been available to us since 2015. So we're just now approaching the 10-year mark with these devices. These devices outperform human comorbidity very, very nicely. So most patients are actually dying of cancers and other issues, although late survival is still cardiovascular related in these patients.
A second point I will tell you is that because of what we are observing with the long-term survival in these devices, we are now starting to think about the concept of net prolongation of life. So in the past, we used to think, should we put an LVAD in or should we do heart transplantation? And now we are thinking about a strategy where we would consider an LVAD first, give the patient a chance for remission or recovery. If that doesn't happen, then perform a heart transplant as indicated. That will require a policy change, at least in the US, in terms of allocation of priority of hearts to those who have more time on an LVAD. And we are moving in that direction now so that we can think about the maximization of life for these patients.
Thank you, Mandeep. And a short question. In the diagnosis of rejection in the heart transplant, are you using DNA-free cell?
Yes. Thank you for that question. So the question relates to the use of cell-free DNA, which is donor-derived, and we are looking at it selectively. What I can tell you is that while its negative predictive value is excellent, which is about 98%, its positive predictive value is not very good. It's about 6 to 7%. And that test does not discriminate the phenotype of AMR versus cellular rejection. So it's a good test to exclude the presence of rejection, but it's not a very good test to help us understand rejection better. We are now doing a clinical trial, a randomized controlled trial called the ACES EMB trial, which we have just launched, and the first few patients have been enrolled, which is randomizing patients to the cell-free DNA versus continued biopsy-based standard of care. And in about 2 years, we'll be able to report out the results of that study, and it will teach us how useful the test really is.
Okay. Well, thank you, Mandeep. Thank you very much for contribution. I hope we'll see you again. Bye-bye.
Thank you so much.